because obviously, when any of us are bored, we just reach for our phones.
Yeah, I'm guilty.
Yeah, so we have to counsel against that because screens can make it harder for the brain to recover.
Hello.
Hi.
Welcome to the Dr. Gil Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Komal Ashraf. Welcome to the show, Komal.
Thank you. Nice to be here.
Komal is a colleague of mine here in mid-Missouri. Komal is a board-certified neurologist, and she has a subspecialty certification in epilepsy.
I do.
And you also have a lot of expertise in traumatic brain injury and expert all around the country, I understand.
Oh, well, that's generous. Thanks, Gil.
Wonderful. Now today, Komal, we're going to talk about concussion. Okay. Concussion is something that's on a lot of people's minds. It comes up, you hear it in the news, particularly around football players. And I have a question right off the bat. I like to watch what you would call pugilistic sports, boxing, and even more so mixed martial arts. And what I like about MMA, probably most fans do, is if you blink, you missed it. It can be over with in an instant with one of these knockouts, a kick, a punch or something. And the guy's out, and you can see it sometimes. The guy gets hit, or a gal gets hit, and you can tell they're out on their feet, and they fall unconscious. Is that a concussion?
Yeah, so that's a great question. Concussions are defined by the symptoms that occur either immediately after the concussion or the head injury happens, or even weeks to months later. So, definitely if somebody in any sport or gen pop has a brain injury or trauma to the head or neck, they're at risk of having a concussion. But we have to see some manifestation of symptoms. Definitely if there's loss of consciousness, dizziness, things like that, then immediately you could diagnose somebody with having had a concussion.
Yeah, because it's managed very differently in the NFL now. It's a guy. When they're knocked unconscious, they go into a some kind of protocol. The doctors take them off. They go into that little tent or whatever, and they go into or the locker room. They go into a protocol. In MMA or boxing, they gave him 8. At least in boxing, they gave him 8. Or do you feel good? Yeah, I'm fine. They got pride. He doesn't want to quit. So now you have a guy that might have a concussion. And we'll get into this later. From what my understanding is, the brain is sensitive and healing. You don't want to injure it again. Yet in a boxing match, here's somebody with a concussion and they're going in for more.
Yeah. So I think that part of that is the spin that media has. We have and we know about the major stories that have come up in the news or social media of pro football players or even collegiate level football players that have been injured, that have had negative consequences that are then in the news. But it's very common in many sports.
Let's start there. When should a parent be concerned that, gee, my kid just got hit in the head, or he wasn't witnessed, they fell off their bike, they come in the house, they're a little bloody, chipped tooth or something? What should alert a parent that, gee, my kid might have a concussion?
Yeah, so I am a parent of 2 girls, and I would say that if at any time someone's uncomfortable or something, there's a gut feeling that something is not quite right, then the person should be evaluated. But definitely the things to look out for, behavior or mood or mental health things, sleep patterns being off.
Now the next few days, their kid isn't sleeping normally.
Right.
I didn't know that.
Or headaches or pain in their head or neck, that if there's a neck injury, you have your head banging around in a counter-coup fashion.
Would you explain that, please? That comes up all the time. Please explain that.
When there's impact to the head or neck, there's there's force in one direction, and the skull is a closed vault system, so there isn't anywhere for it to go, right? So if a bone goes in a different direction than it's supposed to, it might break and come out of the skin or have that in the head. Instead, it just bangs against the skull, and then just like physics necessitates,
right.
you have an opposite force in the opposite direction, or force in the opposite direction, and then you have the head hitting the other side of the skull. So back and forth and back and forth. So that's the coup. Counter coup is the opposite.
So you can have an injury here and an injury 180 degrees the other way.
Absolutely. So
wow.
Then to sleep and mood. Then if you have trouble, if a parent notices trouble with the kid's memory or processing, multitasking, like please put your socks and your shoes on and your coat on. Let's get in the car, get ready for school or work or daycare or whatever. And the kid just is not doing that. You also have coarse pain. That's one of the more obvious things.
Like a headache.
A headache, neck pain, yeah, definitely. And then also difficulty with balance or proprioception, or knowing where your body is in space. So if you notice that your kid is unstable or their eyes are acting weird, then of course there are things like more zoning out or spacing off, and that kind of goes into behavioral things.
So what kind of time periods we're looking at? Obviously, a kid comes in, you know they had an accident. Say, oh, go sleep. You're a little sore. Go sleep it off. So is this stuff you'd see a day later, a week later, a month later?
Yeah, that's
all over the place.
Yeah, so all over the place. The great, one of the great things we're trying to do is get people seen quickly, just because there is opportunity to make improvements. We know that signs and symptoms of concussion can occur immediately. So dizziness, loss of consciousness, sleeping, so the hypersomnolence or oversleeping in the initial stages. And then those symptoms can evolve 8 weeks out from the head injury. So new symptoms of concussion can happen. So we're kind of finding that the sweet spot of getting patients seen is about in 2 weeks, because people are kind of settling into their symptoms, and keys have to turn to be able to get people in. But patients aren't having to wait 8 weeks. And then follow-ups every month, because it gives us a chance to pivot, addressing different issues that someone might have. And you mentioned something that I actually really want to make sure of clarifying, because a lot of people think that after a head injury, you're not supposed to let someone sleep. Keep waking your kid up. I'm not supposed to let him sleep. And so if my kid gets hit in the head, I am sleeping probably in the hallway on the floor, just to make sure that they're not, their sleep is what to observe it closely. But really, hypersomnolence or excessive sleepiness after a head injury is pretty typical, and you should let your person that has been injured, your loved one, sleep if they need to.
So I assume there's healing. I mean, there's a healing process,
absolutely,
right?
Yeah.
Is it fair to say kids heal faster than older people? Is that fair when it comes to the brain?
So it's interesting, that saying that kids are resilient is always a thing that happens. It's just so variable with head injuries. The other thing that we see is, kids' heads are fuller in the cranial vault. Right?
What does that? What do you mean?
Because they, just like as we age, we shrink, so a little bit, and kids' brains are extremely full, that they don't have a lot of space in the head to move around.
Is it true the head grows because the brain is stretching it out? Is that true?
Yeah. I mean, that's why, the circumference of the head is measured at every well child visit for a while. So yes, that's typical, because you want to see the brain grow. And so if you ever see kids neuroimaging, they have, really full brains in their head. And so there's a lot more opportunity for swelling and things like that. Then you can see all severities of head injury happening at all ages, and they're not all created the same. So the exact same injury in someone of the same age, their symptoms might be completely different. So it's hard.
I always thought that nausea, signs of a concussion.
Definitely a more severe concussion, because that might suggest an intracranial hemorrhage or
a bleed. That's a bleed in the brain.
A bleed in the brain, absolutely. So that is something that we definitely worry about, and we want to have somebody go to the emergency room right away or get neuroimaging right away and not wait on. I think the thing that makes adult concussions different is that there is a change in their productivity. So their contribution, right? So as a parent or as a student or as an employee or as a spouse or as a, whatever their profession is, can be impacted. So that has downstream consequences as well.
Another metric that you can use to evaluate someone, Johnny's just not the same past couple weeks at work.
Yeah, right. And so, for example, if an adult who has a public service, police officer, firefighter type job, if their processing speeds are not, and their memory is not as intact as it previously is, we definitely can see manifestations of the concussion, which then so many of us have assigned value to what we do. So then we can see downstream consequences of mental health and behavioral health if they're not able to be as productive as usual.
Is there anything to make you think a concussion or falls occur in nursing homes? And we're taking care of my mother-in-law right now in her 80s. She could fall in our home and could potentially hit her head. Is there anything to look out for in our elderly folks that might have a concussion?
Yeah, so a lot of the same things, because we talked about brain bleeds very commonly in kids because of the closed vault system, the closed space that the head is. We can see more intraparenchymal or tissue bleeds. In the elderly, because of more space, we often see subdural hemorrhages.
These are the tissues that line the brain, and there's some big blood vessels in the dura, the arachnoid, all these things that can bleed.
Yeah, they can get injured and rupture and then bleed. So definitely, as you said, there can be baseline neurologic conditions that are happening in the elderly and really at all populations. The goal after a head injury is to try to recognize a concussion or opportunities for improvement and opportunities to address the things we talked about, but sleep, cognitive, behavioral or mental health, pain, vestibular or movement related things as quickly as we can to return someone back to their baseline. So when we have an elderly patient or person that gets injured, it's really important to understand what their baseline was and try to return them back to what that was as quickly as possible. So they may already have memory problems, but then if they've become exacerbated after a head injury, we want to try to address that as quickly as possible.
Interesting. So let's get back to a football player. We had mentioned Friday nights, big time for high school football. Johnny gets hit in the head. Maybe he doesn't lose consciousness. Maybe he plays out the rest of the game, but now he's not quite himself. Parents saw a big hit or something, say, well, maybe Johnny's got an injury. How do you evaluate someone with a suspected concussion?
So there's immediate sideline testing that happens by
Yeah, tell me that. I always see the doctors on the sideline doing all these things. What are they looking for, please?
most of the time it's probably an athletic trainer, but there's usually, if it's a public school here in Missouri, there's probably a sports medicine physician on the sidelines. According to MSHA regulations, that's a requirement. The collegiate level, they have athletic trainers and sports med physicians that collaborate with their ATs. So they do their sideline testing, which is usually a SCAT, or sports concussion assessment tool.
Okay.
And so that evaluates. There's also the GCS, or the Glasgow Coma Scale. So looking at movement, speech, and eye movement. So motor skills, eye movements, and speech.
So there's a standardized little protocol we see them doing over there that's evidence-based and standard of care, best practice.
Best practices, yes. And so recently, the sports world has come out with the SCAT-6. And so that is the SCAT testing that's done on the sidelines.
What is the SCAT-6, please?
So it's a bunch
I'm not putting you on the spot there.
No. A bunch of really smart people have come together to figure out what paradigm of testing to evaluate all of these things in the quick and dirtiest way possible on the sideline. So those questions involve scoring sleep and score, and that's not as applicable on the sidelines, but eye movements, so saccadic eye movements, whether there's an nystagmus, also
These are just abnormal. Just I'll just translate. These are abnormal movements that kind of jerky or they're not following.
And then balance things. So looking at dizziness, how well can someone walk tandem? That's kind of the standard heel to toe, the drunk test.
Now you mentioned vestibular. That means balance,
right?
Inner ear balance.
And vestibulo-ocular system. So the balance with the eyes is a very commonly affected network after or as a result of a concussion. So the SCAT evaluates for that. Also consciousness and memory. So we give them a string of numbers and ask someone to recall them, repeat them, and recite them backwards. And that string of numbers can be up to 7 sometimes, colors and words that they should be able to remember and recall and recite back. So all of those, and if it's a kid that's being tested, there's a separate SCAT for an adult and the kid. And then if it's an adult, it's just their assessment. And these SCATs are also reproducible. So you mentioned evidence-based. So the SCAT is evidence-based, they're reproducible, and it also helps to guide when we return a person back to play at times. So athletes, athletic training, or sports med team can help do daily SCAT testing to see. So that's what happens at the sideline.
Okay.
And then I think the sideline coverage, and I've never been on the sideline, so that, every team probably does it a little bit differently, but they want to then triage people appropriately. Say, hey, you probably should go to the emergency room, or hey, you probably should sit this game out. We'll see what you can do for practice, or you should go see your primary doctor, or I think you're, totally fine, or whatever. So one of the things that me and my program staff is trying to do is a lot of public awareness, and that is everything from athletes to parents to coaching staff, because we want everyone at all levels to be able to advocate. So when that happens and someone needs to be seen sooner versus later, then we have designed a one-step process for somebody to be seen and evaluated by a concussion subspecialist.
Tell me about that. I'm fascinated.
So we try to shoot for seeing somebody as quickly as possible. This is sports or non-sports related once the referral comes in, especially if it's an acute injury, meaning it's recently happened. So
we're talking hours.
Hours, days, hours or days, even short weeks, before we get into kind of that subacute range. But our goal is as quickly as possible.
Okay, you can't do it too fast. Kid gets creamed on the sidelines. You can put him in an ambulance, take him to the hospital right away. Nothing wrong with that.
Right, absolutely. There's nothing wrong with that. Oftentimes our referrals are coming from the ER and urgent cares, but then the referral process, whether it's within the MU, then person makes contact with the patient, gets their history, the usual information, and then sets that patient up in clinic to see a concussion subspecialist. And that is either someone in PM&R or a physiatrist.
That's physical medicine and rehabilitation.
Yep.
Physiatry is pain and anesthesia kind of related stuff.
So someone in PM&R or in neurology. And so that's kind of our medical team. And then we collaborate very, very closely with PT, OT, speech, and neuropsychology.
Okay, it's physical therapy, occupational therapy, these rehab people.
Yeah, physical therapy, occupational therapy, speech therapy to help with the cognitive things, the task-related things like occupational therapy, speech-related things. So working to rehabilitate all those things. And then on the medical side, we try to optimize. Well, of course, we want to know someone's baseline. We will do the diagnostic testing if and when needed.
You were surprising me, Komal, is you haven't said put him in the CAT scan machine or put him in the MRI machine. You're shaking your head like that's not part. I would assume kid comes in off the foot, if somebody comes in from a car accident or something, the first thing you're going to do is scan their brain.
Yeah, so
I guess I'm wrong.
Well, in the ERs and urgent cares, for sure, they're probably going to scan someone's brain at all ages. I think in the outpatient setting, we want to do that prudently. We want to make sure we're getting a really good understanding of someone's baseline, where they've been before this injury happened. So I often ask, if before the injury you were at 100%, self, your usual 100%. Where are you feeling at your worst, in terms of the functioning person that you usually are? And then we want to ask about how has their sleep changed? How have their headaches changed? How is their mental health and their cognitive health? And their balance, dizziness. We get that full history, which can sometimes take up to 45 minutes. And then we decide on what testing somebody needs. Do they need an MRI? Do we need a CAT scan? If we do, what kind of the neurologic exam testing do they need? Do they need a neuropsychology evaluation? And then I would say most patients would benefit from some sort of physical, occupational, or speech therapy evaluation, and then customized treatment plan.
Does a concussion show up on a CAT scan?
No.
You see, because I know a stroke, a bleed, these things show up, a tumor, these things show up on these scans. But I'm learning from you that a concussion doesn't create a lesion, in medical term, an abnormality or a boo-boo that you can necessarily see. So you can have a normal scan and have a concussion.
Yeah, so a concussion is a clinical diagnosis. There can be imaging findings. So a concussion, there are varying definitions, but I think the most accurate is a mild TBI, mild to sometimes moderate TBI.
That means traumatic brain injury.
Right, with symptoms. So if somebody has pure imaging findings of like a contusion or a small little blush/bruise on their brain after head injury.
Okay, you can see that.
You can see that. But if they are not having any symptoms, that would not be diagnosed as a concussion.
Was that still a traumatic brain injury?
That would still be a traumatic brain injury. So mild to moderate traumatic brain injury plus symptoms would be concussion. And so we can still diagnose somebody with having had a concussion or suffering from a concussion, even if their imaging is perfectly normal. So when we do imaging, we're really trying to just rule out bad stuff.
Those other things.
Yeah.
Beyond concussion,
right.
fractures, or what have you. Well, I love these interviews, Komal, because I end up learning so much. So let's say somebody has a concussion. Obviously, if they're an airline pilot or a surgeon or I guess an accountant during tax season, you got to say, look, you need to take some time off, right? So how do you follow somebody with a concussion, and how do you know when they can go back to work or their normal activities?
So isolating brain activity, isolating physical activity, just dark quiet for a very long time. Now our practices are an evidence-based practice is not to do that for extended periods of time, kind of maximum about 72 hours. And
I'm thinking of bubble wrapping my kid, around and around and cocoon them.
Yeah, so it's basically like that. We think dark, quiet, as boring as possible, and that's how I counsel my patients think about something as boring as possible without your phone, because obviously, when any of us are bored, we just reach for our phones.
Yeah, I'm guilty.
Yeah, so we have to counsel against that, because screens can make it harder for the brain to recover. So we do that about 72 hours, and then we start transitioning people back into a slow, graduated, often supervised return to activity. Not 0 to 100, but slow, incremental return. And we think about cognitive return to activity first, but alternating with physical return to activity as well. So, and then we try to counsel intensity and duration. So, for example, if you're whatever your work is, with your practice skill, so we might say go for a quarter of the day, and it's hard for you to probably decrease the intensity of your work when you're on.
Right.
So we might just say, go back to your work for 25% of the day for a few days. See how you tolerate that. If you have worsening of symptoms, stay at that. Maybe decrease it a little bit. Try to lower the intensity a little bit. Do that until you're symptom free. Then escalate to maybe half the day, then 75% of the day, then a full day. If you have an athlete, we try to do very minimal impact kind of things. Walk, pedal an echo bike, something like that, to see how, and not at full capacity, not at 8 out of 10 in intensity, but lower intensities. Do that for about 10-15 minutes, and then escalate slowly.
But this actually makes a lot of sense. I mean, it seems intuitive. So there's studies that actually show this is the way to go.
Yeah, there are. I think a lot of people think. So I've seen students that have been out of school for a month or 2 months, and imagine the catch-up work or the pressure that they feel.
Or you lose a semester.
Yeah. Or someone who's taken out of the workforce. Where is their paycheck coming from? How? And so that adds a whole degree of stress. We have even high school athletes that, if they don't show up to school, might not be eligible to play. So it's very difficult sometimes, but we try to customize each return to activity. And to do that safely, we also medically see them back every month. So we can do small pivots of, how can we optimize your sleep better? What kind of behavioral or mental health things then can we address, and how? Things like that. So we know that 50% improve within 6 months. If not addressed, it can go out years. I see in my practice patients that unfortunately have had chronic concussions. I have patients that were retired rodeo athletes.
Oh, there's a brutal one.
Yeah. So because of delayed diagnosis and repeated injuries, like you had alluded to at the beginning, it becomes harder and harder to treat those patients. So that's why we're really trying to get people in quickly, diagnosed quickly, intervened appropriately, and then hopefully get people back to their baseline personal, recreational, professional goals and responsibilities. So,
well, other than preventing another injury and taking it easy and slowly returning, are there pills or medicines or interventions or injections or hormones or what can you do to heal the brain from a concussion?
You can sleep well.
So sleep is a real thing. Your brain is recovering and healing, so you gotta sleep.
Gotta sleep.
Okay.
Super important, and there are things we can do, medications, lifestyle modifications, things to help that. So things that are relaxing before you try to go to sleep, avoiding screen time excessively before you sleep, melatonin, other sleep medications that might promote sleep as well can be used. So, there's definitely a lot of things in sleep that we can do. We encourage physical activity that's balanced with the degree of symptoms you're having, because if your body is healthy, then your brain is healthy. If you're physically exerting yourself, then there's a degree of fatigue and sleepiness that comes.
Sure.
It promotes good sleep at night, too.
Sure, nothing helps me sleep better than a day in the gym.
Yeah.
Lifting weights puts me out. It's good sleep.
Yeah. Absolutely, especially if done not right before bedtime.
Yeah.
But yeah. So, and then mental health is really important to optimize, and sometimes that requires medication. Not often, just pure psychotropic medications or medications for anxiety or depression. Usually it's a thoughtful decision of trying to kill two birds with one stone, for example. If someone has anxiety that's increased because of their head injury for whatever reason, and there are many possible reasons, with maybe headaches, maybe propranolol is a good option. And maybe amitriptyline is a good option.
Or the first one is something called a beta blocker, an old-fashioned one. It lowers anxiety and adrenaline. Amitriptyline is was that a tricyclic antipsychotic? They don't even know how they work, but they sedate the brain and have sometimes beneficial effects, don't they?
Well, yeah, and we don't find that it's too sedating now. We use it it's free to use for headaches in little kids. And when I say free to use, I mean there's evidence-based. Amitriptyline or nortriptyline, they're both, even safe in pregnancy. So I feel like those are two of the safest medications. You know that probably better than I do, Gil. But in pediatrics, so the littles as well as the geriatrics population, it's safe, and usually it helps to treat both headaches along with maybe some sleeping problems like insomnia, as a result of a concussion or anxiety too. So those are the two birds, one stone. And I think it is important. There's also a medication that's a combined pill called Nudexta, which is the only one in its class for pseudobulbar affect. So these pro athletes that have gotten significant head injuries, gotten in the news for injuring themselves or someone else, usually it's frontal lobe injury that is causing that. So executive functioning, mood or emotional control, judgment, making good decisions, or kind of impulsivity, multitasking. Those are all manifestations of frontal lobe injuries. So Nudexta is a very specific, clean medication that can be used to help with those things. And then the other thing, we talked about therapy. If someone is not feeling motivated, is feeling down, is feeling anxious, they might not be as motivated in a therapy session, physical therapy, for example. So helping to promote that is really important.
I got to mention nutrition. Seems like the brain is made of fat and protein, and you need a nutrient-dense diet to heal. I assume that makes sense, right?
It does, absolutely.
Sure.
So I'm actually doing a study looking at different types of nutrition that's already been reported then looking at biomarkers in the blood of concussion biomarkers that are still not widely or commonly used, and then their clinical outcomes. So we know that creatine is very helpful to the brain, especially post-traumatic.
Really?
And then turmeric, magnesium, fish oil, B12, all of those help, folic acid, all of those help to promote good brain health. And so another study idea that my team and I are looking at is what kind of supplement group can we offer patients to optimize their outcomes. So definitely, there are medications, there are over-the-counter pills, supplements, vitamins that can be used to try to help promote brain recovery sooner versus later.
Makes a lot of sense. So
but I would just say that none of them are opiates. That's very important. None of them are sedating or like
addictive,
controlled substances. We avoid those things, definitely.
Fascinating. I am learning so much. Now, let's go to the extended end of the spectrum here. Someone that has had recurrent concussions over and over and over. When does it become TBE, traumatic or chronic brain encephalopathy? What is the term?
CTE.
Chronic traumatic encephalopathy. What is that, and how does that relate to concussions?
Yeah, so we know that at a microscopic level, when someone has brain injury and impact, there is microscopic accumulation of blood products. The brain does not usually recover those areas. In terms of tissue, it re-networks, which is an amazing thing about the brain. And that's why I also think young people recover so quickly, is because they re-network so quickly. Kids can learn things, new skills, a lot quicker sometimes than adults. And so a skill doesn't have to be lost, but brain tissue might be injured enough. So repeated impact after repeated impact, you have spaces that then develop and further shrinkage. And so you can see significant atrophy or shrinkage of the brain.
On a scan. So now you can point, with a little pointer, you can go, look, there it is, the damage.
Yep, the ventricles become bigger. The sulci or the grooves in the brain become deeper and wider. And there's just brain shrinkage if head injury after head injury after head injury. We know that clinically, so like their outward symptoms can become much, much, much harder to treat and can compound on one another in CTE. We can also see post-traumatic, headaches that are chronic, or post-traumatic seizures that happen. So there are a lot of downstream consequences. And then you mentioned too, two head injuries or multiple head injuries that happen pretty close together. After one head injury, you're at 3 times at risk of having another. If a second one happens, you're at 8 times risk of having even another one. And it's this vicious cycle that's, we see in pro sports as a problem that I think we want to isolate brain things, but we also know that after head injury, the risk of a musculoskeletal injury goes way up as well. And so it's all very, very connected. And so I think it is important to identify quickly and address quickly. If it's not, and someone goes back to play or carries about their business and has a second impact pretty close without recovering from the first, then they're at risk for second impact syndrome, which is basically significant swelling of the brain that can happen. We have brain bleeding, strokes because of loss of blood flow, and swelling that then causes mass effect of the brain and things like that can be pretty devastating if not addressed. So
Oh boy! So Cocoon, get out that bubble wrap with one concussion.
For only 72 hours at least.
Protect that brain while it's healing, and try to avoid another injury. Boy, I'm learning so much from you. Let's wind this down with an eye to the future. You're in an academic setting. Is there any research going on right now, or future directions you'd like to predict where treatment of concussion may be going? New medicines, new treatments. What are your thoughts, or what do you see?
Yeah. Well, that's a great question. A big question.
It's huge.
I definitely. So I have a passion for advocacy and community awareness, and being a fitness enthusiast, athlete myself. I don't think the answer is in necessarily changing the integrity of an activity. Football should be played as football should be played, with stronger, wiser, smarter brains than mine come up with the rules for that to make it safer play. Prevention is also hard because some people think, well, let's strengthen the neck only. Or let's do this or that. Let's wear this type of adaptive equipment. But I think at one point then it becomes a question about how can this skill, my stronger neck, be leveraged against your neck? Or do I have the resources for this newest and coolest adaptive equipment versus someone else? And so I really think that community awareness, public awareness, advocacy, and early identification and intervention is where the key is. So that's definitely a future direction, is how can we bring more attention to the fact that these can be diagnosed and there are things that we can do about it to make people better faster. The other things are, as you suggested, nutritional things. What can we do to promote brain health? Things as simple as vitamins, promoting sleep, things like, relaxing activities. What can we do, even whether it's counseling on sleep hygiene or physical fitness earlier in the day to promote sleep. So there are those kinds of things. I have specific interests. Currently, I mentioned the nutritional study. I'm also looking at identifying protocols for strength training in people that have been concussed. We have very good protocols for conditioning. So when do we clear someone for conditioning activities? But we have a lot of people that are in the strength community or athletes that do strength training. How can we safely encourage people to get back to their previous loads and lifting? So that's a study that we're doing. Also one that we're working on, and that Siemens and Mizzou, we're trying to have conversations.
Siemens is an imaging company. They make MRIs and whatnot. That's Siemens, yes.
So looking to see what kind of imaging modalities would help to diagnose and follow concussion progression. And there's a lot of research being done on biomarkers. So meaning
like a blood test, a chemical in the blood that changes, will give you some information.
Yeah. Okay. Yeah. So can it be done on the sidelines? And do we see a spike, or does it ER or urgent care and then there's also a lot of research and interest in trying to identify subtypes of concussions. So the brain is extremely intricate. It's a beautiful organ that controls everything: your motor, your speech, your vision, your memory, all of those things.
Yeah.
So depending on where in the head you've gotten hit, your memory can be impaired. Some people not. Some people it's sleep. And so trying to figure out early identification of different subtypes of concussion to then customize their treatment plan as a result. So
that's fascinating. So there is very interesting research going on. And just to clarify, you don't have a colony of mice in your lab where you're injecting some super brain healing drug that you're working on that'll come out in 10, 20 years.
no, unfortunately, I have no injections that we can give Del, and no, I'm not. We're not doing any animal research. So
Gotcha.
I'm not anyway.
Well, Komal, I have learned so much about concussion from you today. What a wonderful discussion we've had. What a pleasure it is to have you a colleague here in mid-Missouri. I'd love to have you back sometime to talk about some other topic in neurology.
Thank you. Thank you so much. Happy to be here.